From Diamond Pharmacy and Optics, this is Podcast RX with Chris Bender. When he's not on the mic, Chris is a clinical pharmacist with the Office of Pharmacy Therapeutics and Integrated Clinical Services, or Optics. He routinely helps providers in correctional and long-term care facilities make better medication decisions to improve patient care. And we're so happy that he's sharing his expertise with you.
Hoping that today can be a real knowledge booster.
A classic Batman and Robin or Jordan and Pippin type scenario.
A full armamentarium of options that clinicians can choose from.
For our first discussion of 2025, Chris explores 3 common sense recommendations that pharmacists and clinicians can draw upon to improve their practice in the new year. Before that, our Into the Clinic segment takes a look at some newly expanded drug approvals and expanded treatment guidelines. And we close out this beginning episode of the year with a 1,000-year look back at the beginnings of what we now know as the pharmacy profession. I'm Adam Campbell, and thanks so much for listening to Podcast RX with Chris Bender. Well, hello, Chris, and Happy New Year. Is it too late to say Happy New Year now? It is January 20th, but for the record, we're recording this because we had a little delay due to some illness. So, Chris, are you feeling relaxed and rejuvenated, not just post-holidays, but from being post-illness? How you feeling?
Hey, I'm a little better than I was last week, and I don't think it's too late to say Happy New Year, considering this is the first time that you and I have gotten together, so it's our first chance to say Happy New Year to you.
Thank you.
But yeah, it's funny. Like, you always feel, you expect to have time off around the holidays. You kind of feel like that's going to rejuvenate you, but it actually is a little bit more exhausting just being the holidays. So I would have to say now that the dust has kind of settled, I feel a little bit more rejuvenated now.
Good.
How about you? How's your New Year starting?
I would have to say the same. The holidays were just a blink, but here we are almost into February, and yeah, that's really it. You just sit back and go, where does it all go? Where you have all these things you want to do and things you get started on, and it's kind of the theme of today's episode, I guess you could say. But and as far as feeling rejuvenated, I mean, you're a parent of young children, so am I. I don't think that ever comes,
Yeah, exactly. You keep waiting for it, but it's like, it just keeps on piling on.
Right, exactly. Well, I do get asked, though, if we're talking about the new year, even if it is, and this is funny, I actually saw a post from OpenAI ChatGPT on LinkedIn today that said, someone had asked ChatGPT, when do most people lose their New Year's resolutions? And the January 19th was the date in that post. So here we are, January 20th, but I do want to talk about New Year's resolutions because it does play into what we're going to talk about later in the episode. But I have to ask from a personal level, Chris, you got any New Year's resolutions you're excited about?
Yeah, so I don't know if it's not like the traditional kind of New Year's resolution per se, but like I used to be really big into music. I was like an avid guitarist back in college. But life happens, pharmacy school happened, and it just kind of like fell to the wayside. So I've been trying to like get back into music a lot more lately. I mean, you and I were even talking a little bit offline. My son he's a toddler now, and he sees the guitars on the wall, and he's always like, "Dad, play guitar." And I was like, well, I can't be disingenuous and not be able to play the thing for him. So I've been trying to do that, try to play the piano a little bit, even though not very well. I've never actually like been trained to play or anything, but he likes to hammer on that. So I would like him to grow up with music, so I figured it would be good of me to try to make more of a concerted effort to play myself. That way, he can get into it too.
Absolutely, and that's fantastic. Music for kids growing up with music has so many benefits in so many ways. So yeah. Yeah,
and I'd be remiss. Do you have any glaring resolutions? Anything on your plate?
I didn't think too hard about it, honestly, this year around, but always, kind of the big things, how to be better financially, how to be, a better parent, how to be a better partner, all those things, and I'm not talking, it's not like I'm, my wife would agree with me here. It's not like a big deficit or anything that I need to overcome. It's just more of how can you be 10% better than you were last year? I guess that's really it for me. So just thinking about those things. But But
Good.
but regarding, I think it's a great resolution, by the way, and kind of channeling that Willem Dafoe meme from Spider-Man, if you're familiar with that. But I'm something of a
Yeah.
I'm something of a guitarist myself, so I'm that really excites me that that's your resolution because, yeah, playing around, getting the kids interested in it, that's a great thing. And Mike, I have a similar things happening with mine where, if I get mine off the wall to play there, they want to they really like the picks and dropping them in the sound holes and things like that, but it's all fun. And,
Yeah. Why is that such a common theme? Because I can
Yeah.
completely relate to that. I've already been retrieving so many
Oh,
out
yeah.
of there. But no, it's funny. It's nice. They make us better, just
They do.
through their own curiosity. It's really cool.
Absolutely. Well, I could derail the podcast very easily by continuing to go down that guitar route, so we won't do that. But let's pivot back to why we're here in the first place. So, in addition to any personal resolutions you have, I would assume that there are things you want to do better as a pharmacist in the new year, and or at least see within pharmacy itself. Is that true?
Oh yeah, of course. I think that's the best part about being a healthcare professional. So like for one, I think us healthcare professionals are just kind of hardwired to always be improving. But the other thing is that the field of medicine is constantly changing itself with new information. So there's always going to be things that need to be improved or that we need to adopt. So we're always kind of striving to improve to keep up with the ever-changing landscape.
Well, we're going to get into those improvements, things that could be improved in the middle of the show in the big discussion. But first, what are some of the most exciting, interesting pieces of medication news to start this year off? Let's take a step into the clinic to find out.
Right on. So, I typically like to start off with like some, new drug approvals, anything fancy that came out in the past month. But, we didn't really have any notable new drug approvals, but we did have a few existing drugs get expanded approvals, or in other words, they just get like an extra approval for other conditions. They were already on the market for something else. So the first is Vtama, which is a topical agent approved now for mild to moderate atopic dermatitis. From my reading of clinical trials, it appears comparable to other newer topical therapies like Eucrisa and Opzelura that have been around for a few years. Typically, because of their cost, these agents are reserved for cases, where topical steroids or topical calcineurin inhibitors are ineffective. Those are, the kind of the first line typical treatments that you see for this condition. Sticking with atopic dermatitis, Nemluvio, which actually I mentioned in last month's episode, is now approved for moderate to severe atopic dermatitis. It's an injectable biologic. Now, it appears comparable to other biologics, those being Dupixent and Adbry, which are also used for this indication. Now, right now, Dupixent is still right now it's the preferred biologic. So it'll be interesting to see if this moves the needle at all in terms of like treatment preferences and algorithms. And then finally, Zepbound, that GIP/GLP-1 agonist that everybody knows about that's being used for weight loss, is actually now approved to treat obstructive sleep apnea in patients with overweight or obesity. Now, this one is notable because it's actually the first treatment approved specifically for sleep apnea. But I should kind of note here, however, that it makes sense that this would improve OSA because OSA is often brought on or worsened by excess weight. So if you think about it, it's essentially doing the same thing that it's been doing already on the market. It's essentially treating this condition simply through weight loss, the weight loss perspective. There are also a handful of guideline updates. Now, obviously, to go into full detail of all of them would be super time consuming, so I'm just going to mention some of their highlights. The American Diabetes Association released their annual update to their standards of care in diabetes. Now, listeners may recall that we recently did a review of diabetes, so I'll preface this by saying that those recommendations on that episode haven't really changed substantially from that discussion. Pharmacotherapy is still going to be driven by patients' comorbidities and treatment goals. So I'd actually encourage listeners to circle back to that episode for a full breakdown. But there were a couple of new things, obviously. First, semaglutide, which is a GLP-1 agonist, is now recommended for those with type 2 diabetes with heart failure with preserved ejection fraction with obesity. I know that's kind of like 3 different things that you have to kind of check the box on there. But if you got all 3 of those things, semaglutide is now recommended because it showed to improve heart failure outcomes in those particular patients. Second, there's an entirely new section devoted to metabolic-associated liver diseases. Those are abbreviated as MASLD, M-A-S-L-D, and MASH, M-A-S-H. These were formerly referred to commonly as fatty liver disease. These liver diseases often coincide with diabetes, given the patient's underlying metabolic dysfunction. These guidelines now recommend that individuals with either of these conditions be treated with semaglutide, tirzepatide, or even a combination of semaglutide and pioglitazone, as recent clinical trial data suggests benefits of these agents in this population. And this is pretty exciting because I know for years there wasn't really, there were really super true guidelines on these disease states. There weren't really any true FDA approved medications for these disease states. It was still a bit of a nebulous topic of discussion. So this, in my mind, is kind of like the first concrete recommendations for this patient population. So it's kind of exciting, and a lot of medications are actually coming out specifically for these disease states. So it's kind of like an exciting area of research. Now, other guidelines worth mentioning include one that recommends the use of metformin to prevent antipsychotic-induced weight gain. Now, weight gain, many listeners may know, is a notable adverse effect of antipsychotics, with some agents being more egregious than others. And metformin has long had data to support its use for this purpose, but I thought it was interesting that this was actually the first guideline to explicitly recommend its use for this purpose. So essentially, this guideline recommends that those patients starting on high-risk antipsychotics, so think clozapine or olanzapine, these patients should start metformin at the same time, so right at the onset of therapy. For those starting medium-risk antipsychotics like quetiapine, paliperidone, and risperidone, they should start metformin at the same time as well if they have pre-existing evidence of metabolic disease. So think hypertension, diabetes, obesity, hyperlipidemia, basically stuff that's going to predispose them to weight gain, or they may have already had weight gain in the past. Now, if they don't have these evidence of metabolic disease and metformin wasn't started at the same time as the antipsychotic, then it should be started if the patient experiences weight gain of 3% or more at any time during the first year of therapy, basically before it gets too out of hand. And then likewise, those starting on low-risk antipsychotics should simply start metformin if they experience that weight gain of 3% or more at any time during the first year of therapy. So hopefully, by employing these guidelines, we can help mitigate a lot of the weight gain that we see with antipsychotics. And now one other notable guideline is from the American Psychiatric Association, and this is regarding the treatment of borderline personality disorder. So this is a mental health condition that affects the way people feel about themselves and others, making it hard to function in everyday life. It often includes a pattern of unstable, intense relationships, as well as impulsiveness and an unhealthy way of seeing themselves. So impulsiveness involves having extreme emotions and doing or acting acting or doing things without thinking about them first. So what's important to highlight about this guideline is that it primarily recommends non-pharmacologic therapy, non-pharmacologic psychotherapy, and it explicitly recommends limiting polypharmacy and the prolonged treatment with medications, simply because evidence hasn't shown that medication is particularly effective for this condition. Now, I should say that the guideline does go on to say that if medications are needed to address some other co-occurring condition like depression, for example, then that's fine. But they do emphasize that psychotropic medications should be routinely reviewed to see if they're still needed. I thought this was an interesting guideline because, as a pharmacist, we often rush to like the pharmacotherapy section of the guideline. What are we treating them with? Which pill for this and yada, yada. I thought it was kind of refreshing to see, particularly with like psychiatric conditions. It's kind of nice to see an admission of, hey, we may not have a pharmacotherapy for this. We actually recommend like the non-pharmacotherapies predominantly. So I thought that was pretty interesting.
Just a very quick question, Chris. What was typically used to or what was typically prescribed rather for borderline personality disorder?
You know, a lot of times you would see like, and I should preface this by saying that like people with borderline personality disorder can often have a lot of comorbid conditions, or their condition could look a lot similar to other psychiatric conditions. So you're going to see patients with like aggression. So they're going to try to treat them with like something a little bit more sedating. So they may treat them with something for bipolar. So you might see antipsychotics. You may see something like one of the quote unquote mood stabilizers like carbamazepine, lamotrigine, topiramate, or, you know, clinicians may interpret their aggression and general you know, like upset behavior as being like a sign of depression, maybe. And then you would see antidepressants like SSRIs and SNRIs and stuff like that. So those are kind of the main drugs that you would have seen in the past. And that's why it's a little bit complicated, because they often have depression co-occurring with the condition. So like, in all honesty, I still think you're going to see these drugs being used moving forward, just because it is kind of hard with any psych condition to isolate like, hey, this is purely borderline personality disorder, as opposed to being able to parse out, you know, whether they may not, or they may or may not have, you know, co-occurring depression. So psych is hard. But if you are able to definitively say it's borderline personality disorder, they have no other comorbidities, then I think this is really, you know, good evidence to say, hey, you should be doing more psychiatric related psychotherapy than just pure pharmacotherapy.
Yeah. Well, that issue of polypharmacy is going to come up here in our main discussion, which we're going to get to right after this little break.
Everyone knows that pharmacists dispense medication, but the clinical pharmacists in Diamond Pharmacy's optics team dispense more potent resources: information and education. The optics pharmacists are frontline medication experts for Diamond's many institutional partners. Whether you work as a provider in corrections or long-term care, the optics team is standing by to answer your on-demand medication questions. But optics is far more than a drug information hotline. They also create proactive knowledge resources like webinars and this podcast to keep partners up to speed with the latest drug developments. And they help providers to better manage costs and therapeutic outcomes with their in-house medication surveillance monitoring program. Learn more about the optics team by going to diamondpharmacy.com and clicking the clinical support tab. See pharmacy care more clearly with optics. Let's get back to Podcast RX.
All right, Chris, as we were talking offline about this month's episode, you sent me a link to something called the Choosing Wisely campaign. And it's an initiative, or it was an initiative, of the ABIM Foundation, that's the American Board of Internal Medicine, to, and I quote here, spark conversations between clinicians and patients about what tests, treatments, and procedures are needed and which ones are not, end quote. This campaign has certainly sparked a lot of conversation in its time among different medical societies and professionals, and you can follow our link in the show notes to explore the impact of the Choosing Wisely campaign a little further. So, Chris, in using the overall theme of this campaign as a guideline, I thought we could have some conversation from a pharmacist perspective, a clinical pharmacist like you, about what tests, treatments, and procedures could use some rethinking. And so to ask a question that could no doubt generate a few episodes worth of answers if left unchecked, what do you think are some wiser choices that clinicians can make when it comes to matters of pharmacy and medication?
Yeah. So, you know, full disclosure to the listeners, I mean, you know, when you and I were talking about this offline, I was honestly not aware that the Choosing Wisely campaign only ran from 2021 through 2023, which I kind of feel like is a shame, because it actually provided an abundance of really thoughtful recommendations that span numerous subspecialties. And honestly, I only hope that this idea gets revived someday, because, you know, as you said, I think it really helps start conversations and bring attention to numerous areas of medicine that could obviously be improved upon. Now, That being said, I actually reviewed all of the. I reviewed the recommendations that would be applicable from a pharmacy perspective, and I can say that most of them are still applicable today, since obviously we aren't that far removed from the time this campaign ran. Now, of course, I can't speak to the validity of those that are more diagnostic or even like they had procedural recommendations in nature, as obviously that falls a bit outside of my wheelhouse. But after reviewing all of the recommendations, I really think it all boils down to a few key tenets. So one is essentially don't do unnecessary testing. Two is don't start medications if they're not needed. And three, avoid using multiple medications that carry similar risks if possible. Now, of course, when you say it this way, this all seems very commonsensical, but I understand that sometimes it's hard to avoid this when you're in the moment. So I thought it would be interesting to discuss a few examples from each tenet. So the first referred to unnecessary testing. Now, I didn't include many for this because a lot of testing obviously falls outside of my scope of practice. So I only included those that would be considered appropriate from my perspective. So the first is not to repeat A1C testing within 3 months for patients with stable diabetes. Now, this is because an A1C is essentially a 3-month average of a patient's blood glucose. So, to measure that sooner than 3 months wouldn't be entirely accurate. And honestly, it would just be too frequent and wasteful spending. Typically, guidelines recommend every 3-month monitoring for those who are not yet at goal, or if you've just made recent diabetes medication changes, and every 6-month monitoring for those who are at their A1C goal. Another big one from a pharmacist perspective is to avoid measuring an INR in patients using non-warfarin anticoagulants. So think Eliquis, Xarelto, et cetera. Now this, I think, is just a case of like where old habits die hard, because for decades, providers were used to monitoring an INR with warfarin to check the level of like the blood thinning. But the newer agents don't impact the INR, and they don't require routine lab monitoring in general. So I thought that was just a good thing to kind of as a gentle reminder. The next two tenets are more focused on the concept of reducing polypharmacy and the potential effects of polypharmacy. Now, longtime listeners may recall that you and I actually did an episode on this topic a while back, but to summarize, polypharmacy is essentially when an individual is taking more medications than is clinically necessary, leading to potentially debilitating adverse effects. So the first of the two tenets is to avoid starting medications when they aren't needed. Now, a couple specific examples from the campaign include avoiding the use of neuropathic pain medications for painless neuropathy, avoiding the continued use of antibiotics without an evident need for them, and avoiding the use of opioid pain medication for mild acute pain. And there are even more generalized recommendations. Many of these are from a geriatric focus, but I think they still could be applied to the general population as simply a good rule of thumb. These include the following. Don't use or continue medications in those with limited life expectancy, obviously unless it's felt that the patient can truly benefit from the medication. Don't start medications to treat a new symptom without first assessing whether the symptom could be simply a side effect from an existing medication. Don't use anticholinergic medications in older adults without first considering safer alternatives or non-drug measures, since obviously anticholinergic drugs can lead to memory impairment and falls. And don't use tramadol in older adults without first considering the risk of serotonin effects, seizures, falls, and potential drug-drug interactions. And the final tenet is to avoid using multiple medications with similar risks to avoid the incidence of adverse effects. Now, to be clear up front, this obviously cannot always be avoided. However, the general recommendation is to always be aware of the risks and simply just make sure that the benefit outweighs those risks. So some specific examples include one from gastroenterology, which recommends avoiding the use of multiple medications that increase the risk of bleeding. Now, these include anticoagulants, antiplatelets, aspirin, SSRIs, NSAIDs, and corticosteroids. Other examples come again from the geriatric space. These include the recommendations to avoid combining opioids with benzodiazepines or gabapentinoids, think gabapentin or pregabalin, to treat pain. and to avoid using 3 or more CNS active medications together, like opioids, benzos, muscle relaxants, psychiatric medications, and the like. This is due to the risk of oversedation and falls. And one last recommendation that is kind of applicable across all of these recommendations is that for those individuals who are transitioning between sites of care, say they're going from from a hospital back to a nursing home or something like that, medications should not be continued without having a pharmacist review them first. Obviously not delaying care, but shortly after their admission, their medications should be reviewed. And this obviously allows the opportunity to identify unnecessary medications, duplications, and potential interactions. So obviously that's my shameless little plug for my profession and role right there. Overall, I understand listeners may think these are pretty general recommendations, and they are. That's kind of the good thing about it. They can really be applicable across different types of subspecialties and different types of clinicians. But overall, I really like that this campaign brought them to light, because as with anything, big results at the end can ultimately come from the beginning by just doing the little things a little bit better.
Big results can come from doing just little things. That the new slogan for optics, maybe?
Yeah, there you go. I like where your head's at.
Well, I just listening to what you were saying, Chris, I mean, these might be general recommendations, but as you said at the top of the discussion, these tenants can get away from you in the moment. And when you're in a position like yours or in any other clinician's role, I would imagine that an occasional regrounding is beneficial, getting back to the basics.
Yeah, absolutely. And like I said, you're in the moment. You have a complex patient, and they really, they're in a spot and they need relief, and sometimes it's easy just to add something on, and you may not always have the chance or the time to review the medication record, to look at what else they're on. So you could see how easy it is to kind of snowball, and one medication begets another type of thing. A concept we talked about it on a previous episode, the polypharmacy, the prescribing cascade. Right. Medication A causes an adverse effect, and we're not really thinking about it from that perspective. So then medication B is added on top of it. So, in the moment it can kind of get away from you. So these kind of help. And I think they're designed to be general in a way to make it applicable to a lot of different people, a lot of different subspecialties, to make it easier for you to just remember that and take a step back and say, hey, I should consider if they're on another bleeding agent or another medication that could cause CNS depression, or see if this is truly needed in this case, or maybe it was just from that medication they got put on last month. So I think these little reminders can kind of, if nothing else, they can be a little earworm to kind of keep in the back of your mind.
Absolutely. Well, I do want to say that if you want to listen to Chris talk more about polypharmacy in depth, it is a really good episode. It's one of the first ones I think we did together. That goes back.
I think so too.
That's episode 18 of Podcast RX about polypharmacy. Go look that up. And that was from March of 2021, by the way. So all I'm going to say to that is, where does the time go?
Yeah. I didn't remember how long ago it was, but I was like, yeah. I bet this is further back than I remember.
Yeah, I was surprised too, digging back in the archives and finding the date we recorded. So yeah, but do go back and listen to that, and Chris gives a very good overview of polypharmacy, the prescribing cascade, and all the attendant problems with it. So, well, we're just about done here. I'm going to take a quick break, and we're going to come back with some trivia capsule.
In the realm of corrections health, not all electronic health records are created equally. Sapphire EHR is a comprehensive, cloud-based electronic health record designed specifically for correctional health providers. Since 2011, Sapphire has worked one-on-one with healthcare staff in jails and prisons to develop and refine a suite of features and modules to manage total inmate-patient care. From MedPass to dental care to documentation of lab results and creating custom forms, Sapphire's correction-specific features can be scaled to meet the needs of the largest correctional facilities down to the smallest local jails. And it's all backed up by 100% in-house hosting, training, and support, with a 24/7 help desk. Get a closer look at the Corrections EHR deployed in over 400 facilities across 36 states and territories. Visit www.sapphire-health.com and schedule a demo today. Sapphire EHR, cloud-based, compatible, correction-specific electronic health records. Now back to Podcast RX with Chris Bender.
And to end this month's show, because it's the beginning of a new year, why not take a look back at the very beginnings of what we now know as the pharmacy profession? What did it look like thousands of years ago, back in antiquity? Chris.
Yeah, so, as with many of the factoids that we discuss in this portion of the show, the history of pharmacy dates back to ancient times. In Egypt, there are documented prescriptions dating back to 1500 BCE. The most notable of these was the Ebers papyrus, which contained over 700 different formulas and remedies. In the 8th through the 14th centuries CE, significant advances were made in the practice of pharmacy thanks to the Islamic Golden Era. Scholars like Ibn Sina wrote the Canon of Medicine, which systematically categorized herbs and their medicinal properties. This period also saw the establishment of apothecaries as distinct entities responsible for preparing and dispensing remedies. The Renaissance era, circa 1450 to 1650 CE, also saw advancements in the practice of pharmacy with the emergence of the study of chemistry and the printing press, which allowed for the widespread dissemination of the first official pharmacopoeia, a book containing directions for the identification of compound medicines, in 1498 in Florence, Italy. The 18th and 19th centuries saw the birth of what we consider modern pharmacy here in the United States, starting with the first known apothecary opened by Irish immigrant Christopher Marshall in 1729 in Philadelphia, and the first hospital pharmacy established in Philadelphia Hospital in 1752. During this time, there was a growing concern regarding the quality of both medicine and pharmacists in the country, which led to the development of the United States Pharmacopoeia in 1820, which is still employed today, and the first College of Pharmacy in Philadelphia in 1821. Since that time, the role of the pharmacist has evolved dramatically, from compounding to soda, candy, and tonic sales, to prescription dispensing, to counseling and immunization, and finally, to today's era, an expanding role in clinical services and patient care.
And don't forget the podcast era, too.
Exactly. We continue expanding our role.
That's right. Well, of course, the profession continues to evolve in very, very exciting ways, and we're always going to be here to talk about it. So looking forward to that with you. Chris, thank you again. I'm glad you're feeling better today, and hopefully
me too.
The rest of the week isn't too hard on you. But yeah,
absolutely.
But if you haven't already,
thank you very much, Adam.
Oh, of course, anytime, sir. But if you haven't already, please subscribe to Podcast RX or Podcast RX with Chris Bender, where you enjoy your podcasts. Also, rate and review to help us bring our show to more listeners. Hey, we greatly appreciate your continued support. And as a reminder, you can find full show notes with references to the material discussed today by going to diamondpharmacy.com, clicking the resources tab, and then you'll see the blog link, and you can find this month's episode very easily. Chris, anything else to add today?
No, just looking forward to next month's, where I'm not so recovering from being nasally and a little warmer.
Yeah.
Let's hope for that.
Let's hope for that. Yes, February is American Heart Month, so you can probably guess where the direction of our discussion is going to be. We may or may not have a guest on the show next month, too. Still working all that out, but either way, we're excited. So, yeah, that's all I have. And again, thanks everyone for listening. Chris, take care, feel better, and we'll see you all back here in February.
All right. Looking forward to it. Take care.
Right. Take care. Podcast RX features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as the substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
Podcast RX is a production of Diamond Pharmacy Services. Find our show on Apple Podcasts, Spotify, YouTube, or wherever you enjoy podcasts. And where possible, please rate and review. If you'd like to get in touch with the show directly, shoot us an email at podcastrx@diamondpharmacy.com. Thank you again for your support.